My name is Michiel Rienstra. I'm a professor of clinical cardiology and clinical director at the Department of Cardiology of the University of Groningen, University Medical Center in Groningen, the Netherlands. And I was the co-PI of the VIP heart failure study, which we will discuss today on behalf of all our investigators.
My name is Gijs van Woerden. I'm a medical doctor and I'm currently doing my PhD at the cardiology department of the University Medical Center in Groningen, of the University of Groningen. And I'm doing that under the supervision of Professor Dirk-Jan van Veldhuizen and Professor Michiel Rienstra. And I was also the coordinator of the VIPHF study.
The idea for the study raised a few years ago. We, in our outpatient clinic, encounter a lot of patients, of course, with heart failure and preserved ejection fraction, or ejection fractions above 40%, so to say. And thus far, there are no recommendations in the guidelines how to treat those patients. So we have no drugs or therapies which we could apply to reduce morbidity and mortality for this large patient population. And furthermore, in the studies that were published in the past few years, we saw quite a high rate of sudden death in this population. And that's interesting because we did not observe that high sudden death rate in our own patient population with heart failure with preserved ejection fraction. So that was actually the question that was raised a few years ago, that we really needed to study this in more detail. So what we did is we tried to study in patients with heart failure with preserved ejection fraction the mode of death by using implantable loop recorders, which are able to measure the rhythm and arrhythmias 24/7 for a minimum of 2 years continuously. So that's actually what we try to do, and that's why we started the VIP heart failure study. The VIP heart failure study is an acronym for the ventricular tachyarrhythmia detection by implantable loop recording in patients with heart failure and preserved ejection fraction.
So the VIPHF study, or the VIP heart failure study, was an investigator-initiated, prospective, multi-center observational study, which was conducted entirely in the Netherlands. And the patients were included between January 2015 and December 2019 in 4 centers all across the Netherlands. And the main inclusion criteria were that patients had to be older than 18 years of age. They had to have a heart failure, New York Heart Association, class 2 or 3, and an LV ejection fraction of above 40%. In addition to that, the patients were required to have a recent hospitalization or ER visit for heart failure, or symptom relief on diuretics in the past 12 months. And they also had to have elevated levels of NT-proBNP. Other inclusion criteria were the echographic evidence of diastolic dysfunction, and main exclusion criteria were the presence or an indication of a pacemaker or ICD, and recent myocardial infarction, PCR or CABG less than 3 months ago. So we applied these very stringent criteria to make sure we included patients with HFpEF and not patients with solely AF or COPD. And after providing informed consent, patients would undergo baseline study procedures, including a baseline 24-hour Holter monitoring, cardiac MRI, and laboratory testing. And after these study procedures, these patients would undergo implantation of an implantable loop recorder for continuous heart rhythm monitoring. The primary endpoint for this study was the incidence of sustained ventricular tachycardias. And secondary endpoints were the incidence of non-sustained ventricular tachycardias, bradycardias, heart failure hospitalizations, and mortality.
Despite the lower than expected number of patients we were able to include, which is mainly caused by our very stringent inclusion criteria, we had some very interesting findings we recently shared with the public. What was most striking was that the incidence of sustained ventricular tachycardias, which was our primary endpoint, was extremely low. Actually, it was 10 times lower than we anticipated in our design of the study. Interestingly, we observed also a quite amount of clinically relevant bradycardias, and that was something we did not expect before we started the study. And also, it's important to mention here, we did observe a very high incidence of heart failure hospitalization and all-cause mortality, which is in line and may even be a bit higher than the prior studies in heart failure patients with preserved ejection fraction. And we did not see any relation between non-sustained ventricular tachycardias and on Holter monitoring and heart failure hospitalizations and all-cause mortality.
After ILR implantation, all patients were seen for ILR device interrogation every 6 months and yearly with the treating physician. And because the ILR can provide only up to 2 years of reliable monitoring due to its battery life, the maximum follow-up is 2 years. And we are currently with a median follow-up of 1.8 years.
I think that's the main conclusion that can be drawn from the VIPHF heart failure study. We really hope that this is a first step in further studying rhythm events and the mode of death in patients with heart failure with preserved ejection fraction. We learned from the ILRs we implanted in this particular study, but there are some disadvantages of using ILRs, as we have also seen in our study. So we hope that in the future studies with other devices like pacemakers and ICDs in this patient population will help to clarify the terminal rhythm before death. And we're also, of course, working on several sub-analyses of this VIP heart failure study to investigate the influence of certain comorbidities in this mixed bag of patients with heart failure with preserved ejection fraction. So maybe we can find a subgroup of patients who are really at high risk of future events, which we may find earlier and hopefully treat earlier.
I think there are several important messages, but the two most important are that despite the lower than expected number of included patients, the incidence of sustained VT in patients with HFpEF is low, as earlier put by Professor Rienstra. And although not expected beforehand, we observed clinically relevant bradycardias in almost 5% of the population, which is significantly higher than we would have expected beforehand.